अरे बाप रे. So far so good. The first dose अभी एक डोज हो गया तो खत्म. हाँ?
I'm waiting for 90 days to finish.
हाँ वही 90 days वो बोलते हैं ना, उसके बाद नहीं होगा.
Hopefully.
Hopefully. उसके बाद प्रोटेक्शन रह जाए बस.
Yes.
Like first 5 days now, you very scared, you know. Especially you've done a few duties, the spectrum. The first 5 days, so scared. I thought anything is going to happen. And the CT normal, then I thought it's okay. And my physician said you go home and stay. I just shut it off. मैं बोला अभी क्या है? CT normal है ना? क्या करने का है? सोच के. नहीं, one of my onco surgeon friend हमारे hospital का, he was quite breathless. He was becoming breathless just saying a couple of sentences for the first 10 days. He was like, wow. He was just moving for washroom. तो उसको देखने के उसको जस्ट था मैंने. तो इसलिए that starts instilling fear, you know. ऐसे सब देखे थे ना. The worst thing was just a few weeks ago we had lost our batchmate, MD medicine.
Okay.
First 5 days went very bad.
Okay. Who?
His name was Raman Patil. He was one of the top physicians in Dhulia.
That's very sad.
तो इसलिए ना वो वही तो बोल रहा हूँ. First 5 days I was so stressed. Just a few weeks ago in the same hospital where I work. बाद में CT नॉर्मल आया था, ऐसे अभी हो गया, अभी जो होना है क्या करने का. उसके बाद I didn't do CT and all. I never did anything again. 16 days हो गए खत्म. The first day I joined, they showed me 2-3 strokes and ऐसा सब. अरे बाप रे, I was so stressed. Post-COVID strokes. नहीं वो तो है, but and that period was, मतलब the fear factor was dominating the minds of all of us, है ना, till July August.
Very true.
हाँ वो the fear was main rather than the disease. Fear.
Your place it was more also, no? Pune.
It was, yeah, बहुत था. It was rampant. And all friends, their relatives, उनके relatives, सब ऐसा social management भी बहुत हुआ ना. I don't know. You guys had to do that? Finding a physician, finding a place in the hospital, all kinds of natak. Ultimately,
one time when my friend had to get hospitalized, there's no bed.
Absolutely.
They're like, Netra will help you in anything except finding a bed for COVID patient. It was very difficult.
नहीं, bed नहीं है. Then the other problem was remdesivir shortage, tocilizumab. वो सब से गए ना. Very bad. Then let's begin.
Yeah.
I think let's begin. Manasi, we are beginning.
Yes, sir.
So good evening, everybody. And another evening of fine tutorials. And today we have our first session on CNS demyelination. And as you probably have already seen the flyer, we are beginning with optic neuritis and a very frequently asked question, evaluation of the patient with optic neuritis. And Dr. Astha Takkar Kapila is going to talk on that. She's, as you all know, assistant professor at PGI. I request her to deliver her lecture. Astha.
Thank you, sir. So I'll share my screen, sir.
Yes. You go ahead. you can begin now.
So yes, at the outside, again, thanks a lot, Dr. Pujari and everybody related with fine. And as Sir has already given the introduction, so what we'll be talking about today is how to evaluate a patient of optic neuritis. So though the topic looks primarily ophthalmological or neuro-ophthalmological, it is important because all optic neuritis are usually associated with some sort of a CNS involvement. So, sorry. So my screen is visible now, sir? I think there is.
Yes.
Yes, it is visible.
All right, all right. So beginning from here, I mean, all optic neuritis is not, or all optic neuropathy is not optic neuritis. This needs to be understood because optic nerve involvement per se is called as optic neuropathy. And the causes of optic neuropathy can be multiple. And one of the causes of optic neuropathy is the demyelinating inflammatory cause, which we call as optic neuritis. So automatically, all the other causes of optic neuropathy come in the differential diagnosis of this optic neuritis. So as I just spoke, demyelinating inflammatory variety of optic neuropathy becomes optic neuritis. So let's talk about the incidence of optic neuritis. It is around 1.03 to 6.4 per lakh population per year. And this data is a universal data. Different countries have different instances. So moving on to further slides. So recognizing the optic neuritis anatomically. So this is important because all optic neuritis would not involve everything related to eye. So this over here, I've just put an image of MRI showing you the optic nerve, and this is the representative anatomical image, which shows you that yes, the eye is connected from here. This is papilla. Anything which is going to involve this optic disc head is actually anatomically known as papillitis. Anything which is behind this is the retrobulbar segment. And if the inflammation occurs over here, it is known as retrobulbar neuritis. Another important thing to recognize is that this area, the optic nerve area, is also consistent of some other structures, most prominent of which is optic nerve sheath. And in case this optic nerve sheath is involved in isolation, this is known as optic perineuritis. So when the core of optic nerve is not getting involved, it's the sheath, it is optic perineuritis. And in case anything else isn't getting involved beyond this disc of, or beyond the optic disc head, which means the peripheral retina, it is known as neuroretinitis. So while papillitis and retrobulbar neuritis is what the neurologists seen most commonly, also to be remembered is a few diseases or optic neuritis or optic neuropathies are associated with the involvement of this perineural sheath, which is usually suggesting a inflammatory disorder of structures beyond optic nerve. So this can just give us a clue what all is not optic neuritis. So another important thing to recognize is to recognize patients of typical optic neuritis. So in general, when we speak optic neuritis, we imply that it is a case of typical optic neuritis, which means an idiopathic optic neuritis or the one associated with multiple sclerosis. So etiologically, any optic neuritis which has a cause beyond this, beyond the idiopathic variety and beyond multiple sclerosis, becomes an atypical optic neuritis or an optic neuritis associated with atypical features. So this is important. This functional classification is important because of major implications in treatment of these disorders. So at least a typical variety and a variety with atypical features should be recognized. And the key to effective management is accurate diagnosis. And hence we come to this slide which says that diagnosis is the most important part of our evaluation. So while we are diagnosing, we need to know what is the course of a typical patient with optic neuritis. So a typical patient with optic neuritis actually has a subacute disorder, which is caused by inflammation within optic nerves due to inflammation or demyelination that leads on to visual impairment. And the visual impairment predominantly involves visual acuity, color vision, and contrast sensitivity. So important also is to recognize this natural course of a patient with typical optic neuritis, which is 1 week is the time taken for the vision to get deteriorated. The vision usually plateaus or stabilizes for next 2 weeks, and it is only after these next 2 weeks is the spontaneous improvement phase, which starts in almost all the patients. So even if you don't treat these patients, this rule of 1, 2, 3 applies, which means 1 week deterioration, then plateau phase, and then improvement, which is also spontaneous improvement. And in case a patient is not meeting this criteria, the patient automatically goes to the atypical variety of optic neuritis. So the typical age of involvement is, as we all know, younger age, 15 to 45 years. And optic neuritis, also like multiple sclerosis, is a female dominant disease. So 6 to 7 per one female, 6 to 7 female per one male is supposed to get involved in this typical variety of optic neuritis. Clinical features, we all know this triad of features which occur if optic nerve gets involved, and it is visual loss. So visual loss can be loss of visual acuity, which is seen in around 90% of patients, and visual field loss, which is seen in another 98% of patients. Dyschromatopsia, which means a loss of color vision, in around 94% of patients, and ocular pain in 92% of patients. And also important to recognize is that in around 40% patients, pain would precede visual loss. So even before the patient loses vision, the patient can present with pain in eye. And this is an important symptom specifically in patients who are having a repeat episode, which means when they come with only ocular pain, they do deserve to get an MRI done to look to the status of the optic nerve. This data is predominantly taken from the very famous optic neuritis treatment trial, and this is probably the only largest trial available and done by this optic neuritis study group. So coming one by one, visual acuity abnormalities. So around 90%, as I just spoke, patients, these have their visual acuity involvement. It is also important to recognize that around 40% or 35% of patients only have mild visual loss. So usually the vision is better than 6/36 in patients with typical optic neuritis, and it's only around 7% patients who go on to develop perception of light types vision at nadir in patients of optic neuritis. Most of them have a progressive disease, and all of them should ideally have a relative afferent pupillary defect, showing us that it's an optic nerve involvement which is causing vision loss. So the slide over here is just to highlight that if a patient is having a vision which is worse than 6/60, in optic neuritis treatment trial, it was associated with lesions in MRI. And today we know that in case this is the vision, it may imply a reference to atypical optic neuritis. So very, very severe loss of vision would suggest that there's something abnormal also occurring in the brain, and this might just be a atypical optic neuritis. So visual fields. So in optic neuritis, we usually have a central field loss or centrocecal field loss, though in optic neuritis treatment trial, almost any type of visual field involvement was seen. Another important thing this slide shows is the visual field involvement in the fellow eye, in the other eye, which is actually the asymptomatic eye for the patient. So in case you're able to see a visual field deficit even in the other eye, you should think that this patient might be having a CNS demyelination associated or a recurrent demyelination of the optic nerve. So it is easy to understand why a central field defect will occur. So we understand that all the peripheral fibers from the eye, they exit or they enter the optic nerve in the perimeter, in the outside of the optic nerve. And the macular fibers are the one which travel in the core or in the center of the optic nerve. So in case these peripheral fibers are getting involved over here, which is the case in papilledema, which is the case in optic perineuritis, what we'll get is a peripheral field loss. But in case this core is getting involved, macular fibers, they get involved just to give us a central field loss. Dyschromatopsia. So we also understand that the eye is very, very sensitive to colors. Optic nerve is the one which carries the color fibers, and the eye is highly sensitive to the color red. And that's the reason why we are checking. When we are checking for the visual field, we use a red colored pinhead. So dyschromatopsia is common, and it's common to see patients complaining of faded red color, faded brick color, or something like this, a red which is looking less red. So it's a common complaint. The optic neuritis treatment trial, however, found that even the other colors are seen faded. They could not find any particular color, but what is to be believed is that color abnormality does occur in optic neuritis. Fundus examination, another very, very important point. So as I mentioned, that papillitis was seen in around 40% patients of optic neuritis, typical optic neuritis in optic neuritis treatment trial, which means around 60% patients were having retrobulbar neuritis. So fundus can actually be normal in earlier stages of optic neuritis and can just show pallor later, showing us that there was some axonal loss, some loss of the core of the optic nerve. However, even in the patients who have papillitis, it is important to remember that the edema which is seen is a hyperemic disc edema, not pale disc edema, not the edema which is seen in ischemia. So it is a hyperemic optic disc edema, and these patients do not have hemorrhages like what we see in papilledema. So papillitis means hyperemic disc edema without hemorrhages. Rest of the fundus is quiet. So this is just a slide to show you what all can be seen when we see various type of optic neuropathies. So one, we have papillitis, hyperemic disc edema. See the vessels, they're very nicely exiting and they're not getting obscured. See retrobulbar neuritis. So you've already developed pallor. Vessels, they are seen normally. See optic perineuritis or something which we see in papilledema. See the periphery, it's all edematous, and see these vessels, they are getting obscured. So this is papilledema or perineuritis, and this is papillitis. And now see retinitis, when we see this either macular star-like appearance or exudate in the peripheral retina. Look at this optic disc. So it is edematous, but look at these hemorrhages. So this is neuroretinitis, optic perineuritis, papillitis, and retrobulbar neuritis. What about the fellow eye? So it's not uncommon to see disc pallor in the other eye, which is asymptomatic, as it is not uncommon to see some visual field defect in the fellow eye other than the affected eye. So other clinical clues are getting paroxysmal visual deterioration or increasing of body temperature, something which we all know is known as Uthoff's phenomena, and Pulfric's effect, which we all know is abnormal depth perception, and phosphine, which is the shining light, which is seen even after eye closure after some time, which is also seen in optic neuritis. So another important thing is loss of contrast sensitivity. So differentiating between the contrasts of objects get difficult. And in acute phase, around 93% patients can have disturbances in contrast sensitivity. So this was all about the clinical symptoms. Important lab investigations. So do not forget to get an ESR CRP complement, which may suggest another clue towards inflammation. In a few clinical scenarios, ACE levels. In some specific scenarios, actually, these days it is believed that all patients of optic neuritis actually should undergo NMO, aquaporin 4 and MOG antibodies tested, specifically in the ones who have visual loss below 6/60 or 20/200 on Snellen's chart. So other infectious workup if needed. And remember that mild CSF pleocytosis may be seen, proteins may be little high, and oligoclonal bands may be present specifically in the settings of multiple sclerosis. So if you do a CSF and you see these oligoclonal bands, that's another marker towards diagnosis of MS, and which we'll be subsequently covering in the other lectures. Of neuromyelitis optica, do remember that in case the pleocytosis is prominent and you're getting optic neuritis, think of other inflammatory disorders like NMO. So now imaging, very, very important part. So we always should know what we are looking when we are looking in the imaging. So while we look in the Google Maps and we are wanting to search for a particular home, it's extremely difficult unless we zoom in. So almost what we require for looking for a typical optic neuritis is to zoom in the MRI and look in this visual pathway. So how do we do that? We do a contrast enhanced MRI brain with cervical spine in specific scenarios with fat suppressed images of the orbit. And that is when we'll start getting images which show these typical optic nerve involvement. Look at the optic nerve over here, completely normal, but over here in the anterior segment, you get a thickened optic nerve with some hyperintensity. So same thing, same visual pathway has to be followed in coronal images, and then you get to see these type of images where now this side, left side optic nerve is normal, right side you see a hyperintense nerve. Now this image, the third one, is showing you a contrast enhancement in a case of typical optic neuritis. Look at the area involved, the anterior 1/3, and it's showing almost very nice, densely enhancing optic nerve in the anterior part, and these are the fat suppressed images. So other abnormalities which you should be able to pick up when you're looking for any patient of optic neuropathy are these. So see on this optic nerve, which is almost like a cord-like optic nerve, thickened optic nerve and is hyperintense throughout its course. So this is an atypical involvement. But you see the optic nerve involvement over here. Similarly, look at this picture. Look at the optic nerve in the coronal image and see the image which is just adjacent to it. So while here you can see optic nerve sheath and the core of optic nerve, in the other eye, in the left eye, you see enhancing optic nerve sheath. And this is typically optic perineuritis. Similar finding you are getting over here in axial images. And these images on top, you can see this is the chiasma. And look at this thickened chiasma. So all these things have to be looked into whenever you are faced with a patient of optic neuropathy. Another imaging which is important these days to be done in optic neuropathy patients is the optical coherence tomography. For retinal nerve, for assessing the retinal nerve fiber layer thickness. It is nothing but just seeing the segmentation of various retinal layers, and you'll get the results objectively in numbers. So what you will be able to see is edema, if any, atrophy in any, in either of the optic nerves, the affected or the fellow optic nerve. So this gets us to the concept of typical and atypical, and I'll just talk about this in the form of a few examples. So a young lady, a young middle-aged or 36 years old lady presenting with pain on eye movements for 7 days duration and reduced vision for 5 days duration. And the right eye vision is 6/24, not very bad, but look at the disc. So once you look at the disc casually, you just don't feel that there's anything on the disc. But just have a look over here when the fundus pictures were taken, and it is very clearly showing that this margin is almost obscured, it is blurred. And we get a visual field which is complete field losses there. So this type of not a very, very angry looking disc, but showing a complete visual field loss was suggestive of optic neuritis. So vision loss, this age, all of these things were making us feel that this was a case of a typical optic neuritis. Look at this MRI. In general, MRI is normal. And when we looked at the optic nerve, it was slightly hyperintense and slightly contrast enhancing. The patient was given steroids over 5 days, injectable pulse steroids. And on 1 month follow-up, there was a complete improvement, giving us that this was a patient of a typical idiopathic, probably idiopathic optic neuritis. Going to say that all the investigations in that patient were normal. So now this is another patient, almost similar age group, again presenting with pain on eye movements of 7 days duration and diminution of vision 3 days duration. And now look at the patient's fundus. Now this patient was having right eye involvement, but the fellow eye also was pale looking, as was the symptomatic eye. And the MRI picture was suggestive of these Dawson fingers. The vision was almost similar, 6/24. But in this particular patient, we had the fellow eye involvement and the involvement on the MRI. So again, this is almost like a typical optic neuritis clinically, but the patient was having MS along with. So typical optic neuritis associated with multiple sclerosis. The patient again improved almost fully. 6/9 vision was the best vision the patient could regain, and the patient was a candidate for disease modifying therapy. And now see this patient. Now an elderly lady presenting with recurrent episodes of visual loss, and the patient had a painless diminution of eye to the nadir of PL negative only over a period of 2 days. So remember that 1, 2, 3 rule. So in case the patient has had this sudden almost hyperacute or acute loss of vision, this is an atypical feature. This age, it is an atypical feature. And a previous history of similar attack with incomplete recovery is an atypical feature. Look at the eye involvement, the fundus involvement. So there was edema, and look at now at this MRI picture showing complete optic nerve involvement, which is another atypical feature. So remember that this particular patient was having a red flag for a typical optic neuritis. And indeed, this patient turned out to be positive for neuromyelitis optica antibodies, aquaporin 4 antibodies, and was treated alike. So very, very quickly, the important patient profile, which tells us that this is not a case of typical optic neuritis, a very young age or a very old age. Hyperacute vision loss, symptoms which progress beyond 2 weeks, complete absence of pain, other field defects than central field defects, bilateral severe involvement, absence of RAPD, and extensive anterior or posterior segment inflammation, retinal abnormalities. And when you look at the MRI, you get a posterior dominant, chiasma dominant, or a complete optic nerve involvement. When you get marked pleocytosis in CSF, extensive optic atrophy when you see optical coherence tomography or when you see the RNFL on OCT, no response or partial response on steroids, and steroid dependency. So I think this is the most important slide of all, when you get red flags for atypical or red flags for typical optic neuritis suggestive of atypical features. So now look at this patient. A young male this time who was a diabetic and a CAD patient presents with an acute visual loss, which was sudden, painless, and on wake up. And now look at this fundus. Now you see a hemorrhage over here, a sectoral hemorrhage over here, and discedema, and an altitudinal field effect. And indeed, this patient was having an ischemic optic neuropathy and not papillitis. So this differences I've taught. So now very, very quickly, I need to show you these images. So now you should be able to spot the differences from the fundus which we saw earlier. So having been seeing these retinal hemorrhages or optic disc hemorrhages like these, this extensive discedema, hemorrhages or involvement of the retina, this all excludes a typical optic neuritis. So after diagnosing these patients, you formulate a plan. And as I just mentioned earlier, do the important lab investigations. And in patients who are above 45 years of age, do consider paraneoplastic workup in given clinical scenario, in suggestive clinical scenarios. After a complete ophthalmological workup, do consider that a few of these patients who present with acute vision loss can also have an infectious disorder or can also have some hereditary optic neuropathies. And these workups only have to be done after excluding all the above causes. So how do we treat these patients in case you are forced with a patient who's only having isolated optic neuritis? In mild or moderate cases, you just give patient a pulse methylprednisolone, and after that, and the patient improves, just observe and follow. What if these patients are having severe visual loss? So after a course of methylprednisolone, see these patients. In case they recover and they recover to a good extent, good enough. Observe and follow up. In case they do not improve fully, and you feel that the visual morbidity is still remaining, the patients can be considered for monthly methylprednisolone pulses. And in case these patients relapse, we may go up a little higher. We may give alternative immunosuppression or IVIG. In case there is no recovery at all, do consider at least IVIG and plaques. Do reconsider your diagnosis, whether it's atypical optic neuritis, and do reconsider that whether this patient can be a candidate for immunomodulation. Other few frequently asked questions. So corticosteroids, is it only to be given in acute patients? So while there are no studies specific for the late onset case or the patients who present, this should be late presenting cases actually. So the patients who present to us late or the patients who present to us with optic neuritis, the usual belief, the best clinical practice is to give a benefit of doubt to all until unless there's a contraindication. So what form steroids should be given? So ideally, as per optic neuritis treatment trial, it should be intravenous. Oral steroids alone were not the treatment of choice for isolated optic neuritis. Though it can be injectable steroids followed by a small brief period of oral steroids. So what about the risk of multiple sclerosis? I'm sure we'll be covering this in subsequent lectures, but still what we need to remember is that isolated attack of optic neuritis, 5 years risk is around 30%. In patients who have lesions on MRI, 5 years risk, after 3 or more lesions goes on to around 50% for developing multiple sclerosis. As special conditions, what if a patient comes with optic neuritis in pregnancy? So it is important to realize that pregnancy is an immune privileged state. However, in postpartum stage is when all the immune related problems occur. If optic neuritis occurs in pregnancy, steroids are not absolute contraindications. So methylprednisolone is though pregnancy category C drug, the risk is considered to be low and the steroids are in general relatively safe in pregnancy. What about long-term benefits of prolonged steroids? We have very, very limited data. So usually it is waited until and unless the patient presents to us with a recurrent attack. High dose steroid efficacy, again, we have limited data. So we have to go from patient to patient basis. What about pediatric optic neuritis? It's usually bilateral, usually associated with excellent recovery, and approach is similar to what we have just discussed. Close attention to be given to rheumatological diseases. Intravenous high dose corticosteroids can be given. And I end my talk with this. Thank you.
Thank you, Dr. Asta. That was superb. I think you covered everything in a short time. Thank you very much.
Thanks a lot.
Let's move on to our second lecture for the day. We are now in MS. So it's on immunopathogenesis of MS by Dr. Shruti Nair, who's an Associate Professor at Sri Chitra, and I request her to begin her lecture. Shruti.
A very good evening to all. Thank you, sir, for the introduction, and I will share my screen now. I hope my screen is visible, sir.
Yes. Yes.
So thank you very much for inviting me. We'll straight away go to the talk. I'll be speaking on pathogenesis of multiple sclerosis. And throughout this talk, I'll be trying to impress upon one major thing, that there are two aspects for multiple sclerosis. There's a neuroinflammatory part and a neurodegenerative component. I'll be trying to show how one can lead on to the other in both directions. So let us start by thinking, how does MS begin in a person? So as of now, we do not know what exactly triggers of MS in a given patient. We know that environmental triggers are there, and there are certain genetic triggers as well. And we also know that more than 70% of the risk is due to environmental factors, and genetic factors play quite a low role. So among the environmental triggers, the most important would be an Epstein-Barr viral infection somewhere in the adolescent period or the childhood period. It has been shown that adults with MS, almost all of them would have a seropositivity for EBV. The other important factors include low exposure to ultraviolet light, vitamin D deficiency, obesity, especially in adolescents, smoking, as well as dietary factors. And when you think of dietary factors, there is more and more data coming which implicate that the composition of the gut microbiota may be very important in triggering of inflammation in MS. Now, unlike other neurodegenerative diseases, say for example, Parkinson's or Alzheimer's, there is no single gene which is associated with MS or which can be causative for MS. Instead, there are more than 200 genes which are identified which increase the susceptibility to MS or modify the disease course. So essentially what we think is that if you have a genetically susceptible individual who is exposed to a sufficient environmental risk factor, there is a chance that this person will eventually go on to develop MS. MS is generally understood as an organ-specific autoimmune disease pertaining to the central nervous system. But there are a lot of differences between MS and other autoimmune diseases, primarily the fact that this progresses along certain phases. So there are three main phases identified for a typical form of MS, which occurs in about 85% of patients. In the first phase, which is known as the preclinical phase or the high-risk phase, there is marked MRI activity without any clinical relapses. And in the relapse-remitting phase, which is the second phase, you have both MRI activity, which is new lesions in the MRI, along with clinical relapses, from which the patient has partial or full recovery. And then comes the last phase, where the person goes on to develop or worsening of neurological deficits, which is independent of the relapse activity. And you can also see that the relapse activity actually decreases towards the end stage of MS. Now, this last part is what differentiates MS from the other autoimmune diseases. Now, this is explained by the fact that MS has two components. It has an inflammatory component, which is responsible for the relapsing activity, and it also has a degenerative component, which is responsible for the progression in MS. Now, it is easy to think that it is a biphasic disease. It starts off as something and then ends up at something else. But we know now that that is not the truth. Throughout the phase of MS or throughout the life course of MS, both exist together. So even at the beginning of MS, you have inflammation and neurodegeneration. And even at the end of MS, you have inflammation and neurodegeneration. So both exist concurrently in MS. So this brings us to the main point of this talk. What starts MS? So is it an autoimmunity which leads to neurodegeneration, or a neurodegeneration which leads to autoimmunity? The most accepted the theory is that this is primarily an immune-driven disease. That autoimmunity is the one which starts off everything. This starts off in the periphery, and then it involves the CNS, and this repeated inflammation is what triggers off the neurodegeneration. But now there are more and more evidence which comes to play, which says that it is not just autoimmunity which starts off everything. It may be possible that neurodegeneration starts first, and that starts off the autoimmunity. Now we'll see the evidence for both. There is no doubt at all that there is some dysimmune process going on in MS. The evidence is from pathology. If you take acute as well as chronic lesions in MS, all of them show inflammation. There is evidence of oligoclonal bands in CSF quite early in the course of MS. The typical animal model of MS is based on inflammation. We know that anti-inflammatory therapy has a great role in bringing down the morbidity and disability in MS. The genetic studies also point towards an immune pathology in the sense that most of the genes associated with MS are associated with some form of immune mechanisms. And there is also increased association with autoimmune diseases like psoriasis, inflammatory bowel disease, and autoimmune thyroiditis. So all of these tend to show that there is a definite immune part for MS. So before we understand the current concepts, let us just take a look into what is the traditional viewpoint of how MS starts, which is otherwise known as the outside-in hypothesis, which means that starts in periphery, then comes to the central nervous system. So adaptive immunity, that is the T cell and B cell mediated immunity, is the one which is most important in carrying out the problems or in being the effectors of the abnormalities in MS, of which till recently T cells were attributed to be the most important players. So the antigen presenting cells in the periphery, predominantly the dendritic cells, present some myelin reactive antigens or myelin specific antigens to the T cells in the periphery. And there is loss of the self-tolerance there. The T cells which get activated become dysregulated because of a reduction in the T regulatory cells and a proliferation of pro-inflammatory T cells, which include Th1 and Th17 helper T cells. These dysregulated and abnormally proliferated T cells now move into the central nervous system. So the migration across the blood-brain barrier occurs through certain specific receptors, which are known as alpha-4 beta-1 integrins on the leukocytes. And once they enter or breach the blood-brain barrier, the T cells now get reactivated inside the central nervous system by, again, myelin proteins which are presented by microglia, which are the macrophage-like cells inside the central nervous system. So they again get reactivated, and as reactivated T cells pull other inflammatory cells into the central nervous system. So they pull other T cells, B cells, macrophages into the system, and then they start off a whole plethora of inflammation and CNS destruction. So this is how we understand the autoimmune pathology of MS. Now, our newer understanding is that, distinct from the previous thought of MS, or traditional thought of the pathogenesis, in which we thought that the macrophages, which were the antigen presenting cells, would activate the T cells, and then T cells are the main players. The B cells become activated only when the T cells go into the CNS and then pull the B cells inside and make them produce antibodies which can produce cytotoxic reactions. We now know that B cells are probably very, very important, and this realization came because the B cell targeted therapies were found to be extremely useful in MS. So this is one example where we have gone from the bedside to the bench. So we know that B cells have a major role in presenting the cells to T cells. They have a role in producing cytokines which are pro-inflammatory, and they also have antibodies which are important for the toxicity. So now we know that it is probably a dysregulation between the T cell, B cell, and macrophage network that leads on to MS pathogenesis, but the CNS destruction which occurs is probably similar to what I mentioned earlier. Now, what the CNS destruction presents as is typically called the MS plaque or the MS lesion. Now, what are these MS plaques? These are focal areas of the brain where you find an abnormal pathology, and the pathology exactly what occurs will depend upon the stage of MS. So you can see that these plaques can occur either in the white matter or in the gray matter. There is a combination of demyelination, inflammation, remyelination, axonal loss, as well as gliosis, which occur in these plaques. And depending upon the stage of MS, there are different types of plaques found in different frequencies or different proportions. So you can have active plaques, inactive plaques, active and inactive plaques, otherwise known as smoldering plaques or shadow plaques. So in the acute demyelinating stage, if you get a plaque when there is a contrast enhancement, what you would see is that the plaque would have a lot of macrophages and microglia, as well as T cells, and some myelin degradation products would also be seen. As it becomes less active, you would see that the myelin degradation products would disappear, but there will be plenty of cells inside them. This is known as an active lesion. Now, this active lesion can go on to have two or three fates rather. About 40 to 50% would become an inactive lesion, which means that this would become acellular, and it would remain, say, inactive like this. There is no myelin and no cells which are seen in that plaque anymore. Maybe 1/3 would go on to, or even half may go on to become what is known as mixed active or inactive plaque, which are very important. They are otherwise known as smoldering plaques. In the central part, they don't have much of disease activity, but towards the periphery, you can see that there is lots of macrophages and microglia, and these keep on expanding at the periphery. And these are the substrates for a progressive disease. And a very low percentage may undergo full remyelination. So you can see that the remyelination part starts in the periphery. And if there is full remyelination, they are otherwise known as shadow plaques. So you can just see the distribution of plaques at different stages of MS. In the monophasic MS as well as the relapsing remitting MS, you get more of the green ones, which are the active plaques. However, you see the oranges start coming only in the progressive one, which are the smoldering plaques or the plaques which go on to expand at the periphery. There is variable amounts of inactive and shadow plaques in all stages of MS. An important category of plaques we should be aware of is the cortical plaque. So you would think that it is a white matter disease, it's a myelin disease. Why should gray matter be affected? So as you all may know, gray matter is affected quite early in the disease course of MS. It is the white matter or the fiber tracts within the gray matter cortex as well as the deep gray matter which undergoes demyelination. And the cortical lesions, more than the white matter lesions, are associated with physical disability, cognitive dysfunction, as well as brain atrophy, which is a marker of disease progression. There is also a peculiar type of cortical lesion, which is known as a subpial demyelination. And this subpial demyelination is associated with a leptomeningeal enhancement, which is due to leptomeningeal inflammatory cell clusters. And this is a factor which is associated with progressive disease. Now, there is a major difference in the outcome of a person depending upon whether remyelination occurs or it does not occur. In a person who these plaques undergo remyelination, they tend to have a better prognosis. And those who have less of remyelination, there is a worse prognosis. Now, when there is loss of myelin, the axons are more prone to have injury because they are not protected against toxins and they have less of trophic support. So if there is failure of remyelination, there is more likelihood of damage to the axon. So the lesions can undergo remyelination. And if the remyelination does not occur, what happens is that the sodium channels in the axon will get redistributed and reconfigured. And there's a proliferation of sodium channels. This leads to accumulation of the excitotoxic, the neurotransmitter, that is glutamate, which then leads to glutamate toxicity. So this glutamate toxicity can lead on to axonal degeneration and eventually death of the axon. So the loss of myelin and the lack of remyelination can eventually lead on to more of disability. Now, what happens when the person goes on to a progressive stage? That is, no significant relapses, but you keep on accumulating disability. Does suddenly the inflammation become a degeneration? It is not like that. Even in the progressive phase of MS, there is a lot of inflammation going on, but the difference is that this inflammation becomes confined to that CNS. So there is no more peripheral, the peripheral control of inflammation probably goes away. And this becomes a self-contained mass of inflammation. But the type of inflammation also changes in that the blood-brain barrier remains intact. The smoldering plaques, the type of, rather than the active plaques, you get more of smoldering plaques with the peripheral inflammation. The normal appearing white matter starts showing a lot of inflammation. So those areas which look normal in the MRI, actually, if you take a biopsy, would show a lot of microglial activation and inflammation. And as I told, the leptomeningeal inflammatory infiltrates also start increasing. So there is a lot of inflammation even when there is progressive phase. And that would explain why we are still trying to give anti-inflammatory therapy when the patient has a progressive stage. Now, inflammation eventually begets neurodegeneration. So we try to see how, in at least three major aspects of it. Because there is inflammation, there is a lot of oxygen-free radicals that is produced. And this reactive oxygen species will lead on to increase stress onto the cellular mechanisms, particularly the mitochondria. This leads to mitochondrial damage as well as mitochondrial mutations, and that will lead on to cell death. Secondarily, as I previously mentioned, when there is no remyelination, there is a redistribution of ion channels. The redistribution of ion channels increases the glutamate toxicity as well as excitotoxic toxicity due to calcium. That will lead on to axonal degeneration. And repeated areas of axonal damage will produce different types of degeneration of axons. So you can have a Wallerian degeneration and a retrograde degeneration, as well as even loss of synapses, which is a trisynaptic degeneration. So all this chronic inflammation can lead on to death of neurons in multiple ways. Now, as a last part, let us just see how the newer theory, that is the inside-out hypothesis. They say that neurodegeneration is the one which starts first, and then you get neuroinflammation as a compensatory mechanism. So how they propose it is that this is primarily, they say that MS is primarily a degenerative disease. And when there is a degeneration, there is a release of antigenic cell components such as myelin MOG as well as myelin basic protein and proteolipid protein. All these myelin components are highly antigenic. So they produce an autoinflammatory reaction, and that is what we see as the inflammatory reaction. So it starts as neurodegeneration, the antigens are shed, and the shed antigens produce the immune reaction. Now, what is the evidence for that? The thought process is that you have degeneration even in the early phase of MS. And in the early phases of the plaques, the inner plaques of the inner lamellae seems to be affected more than the outer lamellae, which is a pointer which says that the problem probably starts with the inner aspect rather than something which is attacking the myelin from outside. And the cortical lesions which are present even very early in the course of MS do not show so much of inflammation, which may suggest that they are the ones which start off the disease, and the other classical active plaques may be a result of the inflammatory abnormalities. And we know that in spite of the best treatment, progression may continue even with a very strong therapy such as hematopoietic stem cell transplantation. There may be disease progression in MS after a fixed period of time. As I told with autoimmune diseases, certain neurodegenerative diseases are also seen more with MS, particularly mitochondrial diseases. So the essential concept is this: all kinds of MS are the same. So you have only a degenerative MS, like a progressive MS. You can see the disability worsening over time. In the primary progressive form, the immune reaction is very less. So you get only the progressive worsening. On the other hand, in the relapsed remitting form, the immune reaction is very strong, and you get a lot of inflammatory activity characterized clinically by clinical relapses. And certain people, the immune reaction is so strong that they may develop some fulminant episodes like Marburg variety. But eventually, it is all the same. And whether it is a primary progressive MS or a secondary progressive MS, we know that it's around the age of 40s or late 30s that the person eventually develops the progressive form of MS. And this is also underlined by a study which has shown that DMTs are usually active when given early in the patient's age, irrespective of how much disease activity is there. The younger patients respond better to the disease modifying therapy, and the older patients respond very poorly to disease modifying therapy. So eventually, as I mentioned, MS can have a complex pathogenesis. There are two main processes which we need to understand. There's an inflammation and neurodegeneration, of which currently the autoimmune model is the most widely accepted one. And the progressive MS, according to this model, results from repeated chronic inflammation. However, newer and newer evidence suggests that there may be degeneration may be a very core component of MS. So when we think of treating MS, not only should we target the inflammation, we should also be trying to look at remyelinating strategies as well as neuroprotective strategies. Thank you.
Excellent. Shruti, that was brilliant. Actually, you covered so much, right from inside out and inflammation to degeneration, everything really. That was great. Thank you very much, Shruti. Let's do our third lecture today, which is Diagnostic Criteria for MS by Dr. Netravati, who is additional professor at NIMANS, we all know. I request Netravati to begin a lecture.
Good evening, everyone. That was a indeed nice lecture previously, which forms the basis for our subsequent talks. Thanks to Dr. Shruti and Asta. My slides are visible.
Yes.
Yeah. So basically, now we're going to talk on the diagnostic criteria of multiple sclerosis. I would want to tell how this criteria has evolved over the years. So before that, I'm just going to give two clinical scenarios for you people to see. This is one case scenario. I'm not going to give the symptoms, but basically this patient had history of some vague sensory phenomenon in the upper limb, and she was imaged, and this was the MRI. So this is the case one. We'll again discuss at the end of my session. Coming to the next case. This is a patient who had come with history of brainstem syndrome, and she had lesions which were there in the brainstem, thalamus, and the spinal cord. So we'll discuss this again. So coming to the diagnostic criteria of MS. So we all know Charcot. He was the first person who described MS. So in 1868, he labeled MS. He labeled this disease as La sclerose en plaques disseminans, which was later called as disseminated sclerosis. And in 1960, this got termed as MS. So many of you may not be aware, he gave the first description of a clinical criteria. So he said, if you see a patient who has a triad of nystagmus, intentional tremor, and a scanning speech, then you can know that it is multiple sclerosis. So he went on taking patients of this triad, and they say that it was less than 20 patients he had who had this triad, but even then he gave a beautiful description, clinical and pathological description on MS. This is called as the first description, the clinical Charcot's triad. After this, it was Marburg in 1936 who gave another clinical triad. This was also considered as a diagnostic criteria. Why am I telling is how the criteria have evolved. Initially, it was just the clinical, but eventually we took a lot of investigations into the diagnostic criteria of MS. But many times we may be handicapped by having less of investigations and more of clinical features. So when we have patients, we should know how we should be diagnosing. So Marburg gave the next clinical triad where he gave Hypoth sign, absent abdominal reflex, and pyramidal tract signs as another clinical triad. So eventually you can see there were many people who gave a lot of criteria. Initially it was mainly on clinical. Eventually all the investigations came, and now we are in the 2007 McDonald revised criteria. So again in 54, it was clinical criteria, but here they started making a distinction between early, probable, and possible. And in 1965, it was Broman who brought the CSF examination into the first picture. So until then, it was just a clinical criteria. But then CSF oligoclonal bands was brought into the diagnostic criteria. So they combined the clinical criteria with the CSF OCBs, and if these were present, they were called as positive multiple sclerosis. We know these criteria which were main of clinical and then CSF being brought, but it was in 1965 Schumacher who gave the first use of a clinical definite multiple sclerosis. So if you look into the diagnostic criteria of MS, this was the official method which was started, though the criteria evolved previously. So he also based it on clinical symptoms and signs. Then there were the McAlpin and Rose criteria, which slightly tried to alter this clinical criteria. Eventually, it was Poser in 1983 where he brought almost all the other investigations. He brought about the CSF, evoked potentials. He even brought about the urological studies and hyperthermia, that is Uthoff sign. These all were combined and he classified them based on this as definite, lab supported and probable criteria. The MRI started coming after the Poser criteria, where they started having a lot of MRI signals. So most consistent was a periventricular MRI changes. So based on that, how many MRI periventricular lesions should be there, or whether any other lesions should be there. So based on that, it has evolved. So Patty's gave the first MRI where it was 4 or 3 lesions, eventually 9 lesions, and then the Bharkov and Tintok criteria. This was the main thing which was practiced up to 5 years back, where we used to take almost 9 lesions, but now it has got simplified. So it was MacDonald who in 2001, he had a panel of neurologists, radiologists, and even immunologists. He combined all these 3, and there was a big consensus. Around 30 people of them brought about the MacDonald criteria in 2001. Eventually, it was revised by Polman in 2005 and 2010. Now we have the 2017 MacDonald criteria, which is revised and which I would like to explain based on few case scenarios. So coming to the first clinical scenario. Before that, the 2017 MacDonald criteria, we should understand 2 features. One is the dissemination in space and the other is dissemination in time. So what do we mean by dissemination in space? For example, a patient has come to you with optic neuritis and you have done an imaging. So if you see lesions apart from the optic nerve lesions are not taken into the criteria of multiple sclerosis. But if you see lesions apart from this area, so you may see in the periventricular, brainstem or spinal cord. So, but the patient has come to you with optic neuritis. So that means there are lesions away from the involved site. This is called as a dissemination in space. And what do you mean by dissemination in type? You can take it as 2 things. One would be that a patient has come to you with brainstem syndrome. You're finding signal changes in the midbrain or the pons. But apart from that, you have some non-enhancing lesions in either the periventricular or the juxtacortical or the spine. So that shows a dissemination in time. So either you have non-enhancing, enhancing lesions, or you find that there is a difference when you have 2 MRIs, you find that there is a difference between the initial baseline MRI and the subsequent MRI. So all this will give you about dissemination in time. So this I'll talk about later. So let us now understand the MacDonald's criteria for diagnosis of MS. So the first clinical scenario. So you have a patient who has come, as you can see, there are 3 episodes of, first was optic neuritis and then the ataxic hemiparesis, and now the patient is asymptomatic. So you have 2 episodes. And when you see the MRI, you're seeing MRI, there are lesions. Basically, you have to remember, you have to look for 4 different sites. First is the subcortical, going from the top, subcortical or the cortical, which has been revised now, and then the periventricular, infratentorial and spine. So these are the 4 different areas. So here you can see bilateral optic neuritis and ataxic hemiparesis. So your localization would have been across the optic nerve, and this could be either at the brainstem or the subcortical region. But when you see the MRI, you have lesions in the spinal cord, infratentorial, juxtacortical and subcortical also. So that means all the 4 areas are involved. So if a patient has come to you with 2 episodes and based on the clinical MRI and other investigations, you have ruled out other exclusion criteria, then you do not require anything else. This is enough for you to diagnose multiple sclerosis. So 2 episodes, it is more easier. You have lesions which is having an objective clinical evidence of more than 2 sites, then you do not need additional data. Your diagnosis of multiple sclerosis is done. So coming to the next scenario where you have another patient. Again, patient has come to you with 2 episodes of optic neuritis. Now you look at her MRI. She has one in the subcortical and one in the periventricular. I'm not taking the optic nerve images, though this patient had optic neuritis, just to emphasize that in McDonald criteria, we do not take the optic nerve imaging or even the hyperintensities which are there as the diagnostic criteria for multiple sclerosis. So this patient has come to you with optic neuritis, but you're seeing lesions in different areas. So again, you go back to the 4 areas. Among the 4 areas, you have here 2 at least areas which are inward. But if you see the criteria, it says that there should be at least more than 1 plaque in these 2 areas at least. So here you can see you have 1. So this would be a possible or a probable, but it wouldn't be a definite multiple sclerosis. But if you see the cortical are there and you see that the subsequent MRIs, you're seeing increase in these lesions, then you may consider it as a definite multiple sclerosis. So this is the second scenario. So you have more than 2 attacks as well as lesions are 1 or clear-cut historical evidence is there. Still, you wouldn't require additional data. So coming to the other 3 scenarios, here it is about a patient either has had 2 attacks or 1 attack, but objectively you have just less than 1 or 1. So what do you do during that time? So for this, we would require few clinical scenarios which I would like to show. Here, for example, this patient has had 2 episodes of myelopathy. You are seeing spinal lesions, short segment, but you have a normal brain MRI. So it is not a long segment myelopathy, brain may be normal, CSF OCB is positive. So you have another one criteria which is giving you a clue towards multiple sclerosis. Then you have second scenario where you have an episode of optic neuritis. MRI shows lesions in 2 of the 4 areas, which I showed already, and your OCB is also positive. Then it gives a clue towards multiple sclerosis. And episode of myelopathy, MRI shows lesions in 2 of the 4 areas. CSF OCB is positive. Then again, dissemination time is met and it tells that it is a multiple sclerosis. So basically, what is the revisions which has happened in the 2017 criteria is the positive CSF oligoclonal bands has been taken as a substitute for dissemination in time. That is the reason the previous 3 clinical scenarios had positive OCBs with not clear-cut evidence of MRI showing evidence of MS. So even then, if there is features where you have excluded NMO spectrum disorders or a secondary demyelination, but there are few lesions which goes in favor of MS, and then you have a CSF OCB, it can be taken as dissemination in time. In 2010 criteria, they had not taken into account the symptomatic lesion. That is, patient has come to you with brainstem syndrome, INO. Then the brainstem lesion will not be taken into your MRI count. But in 2017, they say that you can take even the symptomatic as well as the asymptomatic lesions also into count. Previously, it was subcortical or juxtacortical, but now they have added even the cortical lesion as the revision in the 2017 criteria. That is because it has been noticed that a patient may have come to you with just a myelopathy or an optic neuritis. But a cortical lesion is one of the most important factors which will rule out NMO spectrum disorders. NMO spectrum disorders can have juxtacortical, can have periventricular, but cortical involvement usually does not happen. So that goes, except in MOG-related disorder, where you can have ADAM-like presentation. But except that, cortical lesions goes more in favor of multiple sclerosis. So this is basically the main thing where the revision of 2017 criteria has happened. So just going back, I'm sorry, I think this was a wrong PPT. So coming to the primary progressive multiple sclerosis. Here you take into account that at least a 1-year progression should be there, and along with that, 2 of these 3 criteria, that is dissemination in space in the brain, dissemination in space in the spinal cord, 2 or more lesion, or positive OCB. So any of these 2 is there along with the progression of more than 1 year, then you take it as primary progressive MS. So this criteria has been retained even in the last 2 times also. So coming now to the case which I had described first. So if you take this patient who had come to you with a tingling sensation in the upper limb. So initially she was diagnosed as carpal tunnel syndrome, but she did not respond. And then they found that the paresthesias was not fitting into the carpal tunnel syndrome. So that is a time when she was imaged, and this is her MRI. So when the MRI was done, after this, the neurologist went back and asked few questions and made a diagnosis which was non-MS. Why? If you see here, you have periventricular lesions. But what we have to remember is, it is not just about, this can also be told as a juxtacortical. Few of these are periventricular, but these are coming in between. Moreover, the morphology of the lesions is not perpendicular to the corpus callosum. So these are nothing but, these are UBOs which we see usually in migraine. So on asking back, this patient had migraine and these are UBOs. So it is not enough you just see a white matter lesion. Most of the time they say 30 to 40% of MS patients are misdiagnosed because of not reading the MRI correctly. I'm sure in the next session we'll learn more about how to read the MRI correctly, but I just wanted to emphasize that white matter lesions need not be always MS. Coming to this next scenario, I think the clue here is the spinal cord. Most of you must be aware. So it is definitely long segment and you have lesions which are across your periventricular regions, or the region where your aquaporin 4 is richly present. So this is one of the classical case of NMO, which again, if you don't see properly, you can misdiagnose it as multiple sclerosis. Thank you.
Thank you, Dr. Netravati. So perfect. I think you set the stage perfectly for to learn MRI criteria, and you covered everything right from the historical criteria till to date. Thank you very much. I think it was quite expansive. Let's do our last lecture for the day, which is now the role of MRI in the diagnosis of MS by Dr. Lakshmi Narasimhan, who is the director and head at Madras Medical College. I request Dr. Lakshmi to deliver his lecture. Lakshmi.
Thank you, Dr. Shripad. Am I audible?
Yes, you are.
I just want to share my screen. Is my screen visible?
Yes.
Is it visible?
Yes, yes. It's very well visible.
Okay, thank you. So, we have an extensive coverage of neuroimaging in multiple sclerosis. So, you should understand that presently neuroimaging is almost equivalent to a virtual biopsy. I will show you why I tell that this is a virtual biopsy. You will understand the course of my talk. As it is the neuroimaging of myelin, it could be imaging of the central myelin or imaging of the peripheral myelin, imaging of the optic nerve, imaging of the brain, and imaging of the spinal cord form the parcel of the central myelin, imaging of the radicals, imaging of the plexus, and imaging of the peripheral nerves form the imaging of the peripheral myelin. So neuroimaging in multiple sclerosis, there are existing, I divide them into existing neuroimaging in multiple sclerosis or neuroimaging advances in multiple sclerosis. And existing neuroimaging are for, what are they used for? Diagnosing MS, monitoring the disease activity, assessment of treatment response, or assessment of therapeutic complications. So the imaging MRI is used for diagnosis, monitoring disease, assessment of treatment response, and any complications arising out of the therapy. So for diagnosing MS, the protocol for MRI protocols are T1 axial pre-gadolinium post-gadolinium contrast, T2 axial flare sagittal, MRI protocol in spinal cord imaging, T1 sagittal, T2 sagittal, short inversion recovery, and T1 post-gadolinium. Look at the morphology lesion, oval lesions measuring 3 mm or larger, perpendicular to the ventricle in its long axis, and topographically it may be in the corpus callosum, periventricular, juxtacortical, infratentorial lesions, brainstem or cerebellum. So let's look at this. It could be the deep white matter, or it can be the periventricular, or the subcortical, or the cortical. In the spinal cord, you all also know that it is short segment, eccentric, it plays lesions, and in infratentorial in the cerebellum. So what is the temporal evolution of the lesion? Block phase, imaging characteristics, acute phase, T2 flare hyperintense, that may be T1 isointense or hypointense, and show intense gadolinium contrast enhancement. Beyond the acute phase, T2 hyperintense may persist as T1 hypointense without contrast enhancement. Only T2 hyperintensity, and may persist as T4 hypo without any contrast. Chronic phase, T1 hypointense, which we call it as black holes. About half of the contrast enhancing lesions convert to black holes, and the presence of black holes suggests the development of future cortical atrophy. They have also quantified the black hole volume, which is proportional to the cortical atrophy in future. Conventional MRI and MS, the sagittal 3D flare images shows various lesions involving the periventricular. You can see the classical dorsal fingers and the white matter of the juxtacortical regions. So I don't want to go into the criteria, which already Dr. Netravati has covered in detail. So the Magnum's criteria and the McDonald's criteria. So in patients in whom the diagnosis of multiple is unclear, repeat the imaging after 3 to 6 months to establish dissemination in time. If there are no new lesions, repeat the imaging after 6 to 12 months to establish dissemination in time. If no new lesions, the diagnosis of multiple at the end of 12 months, the diagnosis of multiple sclerosis is unlikely. So now monitoring the disease activity, what are the things? It's better sensitive than the clinical measures in monitoring the disease activity. Lesion load more than 10 has also increased. What are all the monitoring parameters? T2 flare lesion load, contrast enhancing lesion load, T1 hypointense black holes, and cortical atrophy. If you really look at T2 flare lesion load is a better predictor. Contrast enhancing lesion load enhancement lasts only for 6 weeks and disappear when monitored 6 monthly. Black holes occur very late in the disease, hence it's not useful. Early predictor, and cortical atrophy. Then the third thing which I told you is assessment of treatment response. So first we saw diagnosis, second monitoring, and assessment of treatment response. Is again in treatment response 10 times more sensitive in detecting the treatment response than clinical measures. What is NEDA? No evidence of disease activity. MEDA is minimal evidence of disease activity. These are the two. So what is the criteria for NEDA? Freedom from relapse, no new worsening or MS symptoms, no worsening of PDSS score, no new enlarging lesions, T2 lesions, or even gadolinium enhancing lesions on MRI. It's nearly impossible. MEDA, then that's why the MEDA criteria evolved. Either one relapse with less than 2 new T2 lesions, or less than 3 new T2 lesions, or less than 2 gadolinium enhancing lesions in the absence of confirmed PDSS worsening. When to repeat the MRI? 3 to 6 months following the initiation of treatment or following the change in the treatment. 6 to 12 months in assessing treatment response. Appearance of 2 to 5 T2 hyperintense lesions in 2 years correlates with poor outcome. Cortical atrophy is associated with cognitive decline. So this is how you can see how the white matter lesions progress, and similarly the progression of gray matter atrophy. So the fourth one is the therapeutic complications. For example, natalizumab, progressive multifocal leukoencephalopathy, T1 weighted MRI hypointensity, T2 flare hyperintensity in the white matter, in the peripheral bilateral asymmetric, involvement of subcortical U fibers, no mass effect, supratentorial commonly involved, frontal parietal occipital lobes, thalamus more involved than the basal ganglia, crescentic lesions involving the middle cerebellar frontals and cerebellum are more specific for PML. So you can see contrast enhancement may be very little or patch. Diffusion rate in PML lesions varies according to the stage of the disease. DTI in PML shows reduction in the fractional anisotrophy compatible with myelin injury that occurs early in the disease and may detect PML before conventional imaging. So diffusion tensor imaging is the imaging of choice in pretty early PML. So generally what we do in the patient on natalizumab, you monitor them with the diffusion tensor indices like fractional anisotropy. MRS and PML lesions show lower levels of N-acetyl aspartate, elevated levels of choline, variable bioinositol levels. Iris in PML, again another complication of the treatment. Iris PML can occur in patients with natalism associated with PML 3 to 6 weeks after plasma exchange or immunoadsorption. Can occur with PML from weeks or months after discontinuation of natalism, or even when plasma exchange are not deployed. Iris is demonstrated by contrast enhancement mass effect on the lesions. Contrast enhancement mass effects would noted follow-up MRI with PML suggests iris. Daclizumab produced meningoencephalitis withdrawn from the market. So we have shown usefulness in diagnosis, monitoring, therapeutic, monitoring disease activity, monitoring the effect, and then finally the complications of therapy. So existing neuroimaging in multiple sclerosis, neuroimaging advances in multiple sclerosis. Existing, the advances are cortical imaging. This is, I want you to just know this. This is all nice to know neurology. So far what I talked is a must. This is all nice to know neurology. Cortical imaging, iron mapping, dynamic contrast imaging, central vein imaging, microstructural imaging, and phagocytic imaging. So cortical imaging, MS causes involvement of gray and white matter. Gray matter involvement precedes the white matter involvement, correlates with cognitive impairment and clinical disability. Atrophy of the gray matter occurs early in the course of disease. Types of cortical lesions already talked by Shruti, mixed white matter and gray matter lesions, lesions located within the cortex without entering subcortical or pial surface, and lesions that extend inward from the pial surface and stop before the white matter gray matter junction. Cortical imaging techniques, pulse sequence is the best. Best pulse sequencing of the cortical lesion is double inversion recovery. This sequence suppresses the signal from cerebrospinal fluid as well as the white matter. First inversion suppresses the CSF, second inversion suppresses the white matter. 30% is the histological lesions were detected in imaging by these sequences, double inversion recovery. So the cortical imaging shows intracortical lesions with the multiple periventricular deep white matter lesions. The disadvantages of DI, double inversion recovery, is low signal. So there's a new sequence called phase sensitive inversion recovery, PSIR, which has a higher signal to noise ratio and shows clear delineation of the cortex than the conventional MRI imaging. Subpial cortical lesions are still undetectable and remain invisible in the normal field MRI. So these are all the various I can show that this is the 3D double inversion recovery and 2D, 3D flare, and the final one is the phase sensitive inversion recovery. You can see the lesions, what the various, how it is far better delineation in each one of them. Then comes the ultra high field imaging. 7 Tesla imaging compared to 3 Tesla. Flare sequences could pick up more cortical lesions in naive field MRI than DIR due to detection of mixed GM and white matter lesions. And improved detection is by 7 Tesla MRI. Cortical atrophy, gray matter volume, and thickness of the 3D T1 vehicle imaging is a measure of neurodegeneration in MS. Most commonly involved lobes include frontal and temporal regions. Mild cases of MS show focal cortical thinning, particularly involving the primary sensory regions. Thalamic atrophy is a good predictor of cognitive impairment. This is another important thing. In the first episode of a clinically isolated syndrome, people use two things: the retinal nerve fiber layer thickness as well as thalamic volume to say predictive of subsequent MS. This is being used by few other research groups. Susceptibility weighted imaging. All of the MS subtypes have iron deposition in cortical regions. Patients with early MS, clinically isolated syndrome, have higher iron deposition in deep brain. Sometimes iron deposition precedes the development of. So if you look at this, already Madam has shown this slide. So what I just wanted to say is each one of these steps has to say activation, active, inflammation, glutamate excitotoxicity, cell swelling, pH imbalance, demyelination, loss of neuronal activity, microglial activation. Every step in this, there is images available, imaging technology available. I'll just show you, for example, microglial activation, which is a TSPO thesis. Recently, PET used new radioligand developed MS radioligand called CPK, showed increased binding the cortex in patients with MS, actually binds the translocator protein 18K delta, which is a marker of activated microglial cells and macrophages. So you will understand why I told that this is, you can say whether The plaque is surrounded by microglial cells and macrophages by using this marker, almost literally amounting to virtual biopsy. This can lead to prognosticated MS following this. This is the high EDSS score and increased binding, and low EDSS score and the low binding. You can see this is the TSPO imaging. And various other cellular and molecular processes measured with PET. Inflammation, the TSPO tracers, C-PIB tracers, 4-beta-bond, neuronal damage by flumazenil, astrocyte activation by carbon 10. MS spectroscopy for metabolic imaging measures changes in the metabolite concentration associated with axonal loss, reduced level of MS cortical in cortical gray matter is characteristic. So these are all the various in proton MRS, the various ligands, each one is for, I told you, each impaired energy metabolism, the same one I showed in the diagram, each one ligand measures each one of them. And metabolic sodium imaging is called sodium imaging in demyelination. As a consequence of demyelination, because of this, the metabolic failure, the increased intracellular sodium is detected in the lesion, in normal appearing white matter in multiple sclerosis patient. This increased sodium can be measured with the use of ultra high field 23 sodium imaging. So dynamic contrast imaging, one of the recent advances, MS showed with reduced perfusion, normal appearing white matter. Dynamic contrast magnetic resonance quantifies magnetic hyperperfusion of the white matter. Hypoperfusion of normal appearing white matter contributes to the fatigability and cognitive impairment. Statistically found that cortical lesions and normal appearing white matter have significant reduction in cerebral blood flow and cortical blood volume, cerebral blood volume compared with normal appearing gray matter with no change in the MT. So dynamic susceptibility contrast imaging and dynamic contrast enhancing DSC and DCE MRIs are few advanced techniques. It is nice to know them. Then microstructural lesions, magnetizing transfer ratio, diffusion tensor imaging, and I don't want to go into the details. I'll just skip this. And diffusion tensor imaging, if you know, fractional anisotropy, which I have already told you how important it is. Newer techniques in the tract imaging is called diffusion Kurtois imaging. And NODI is a neurite orientation, dispersion, and density imaging. These are all the tract imaging techniques. Diffusion Kurtois imaging is slightly superior than diffusion tensor imaging, and these Kurtois indices are superior than then iron mapping. Already told you that iron is deposited. Increased iron deposition in cerebral gray matter is a marker of neurodegeneration, correlated independently with disease duration, severity, and disability. And this is what the iron mapping in MS. And iron mapping in manual segmentation. This slide. I thank the Sri Chitra group, Dr. Keshav Das. He gave me this slide. I thank him. Central vein sign, the MRI identifiable central vein sign inside the white matter lesion serves as a biomarker for MS. And if you want to accurately differentiate MS from the other MS mimics, the paramagnetic deoxyhemoglobin, the venous blood disturbs the magnetic field, low signal intensity, causing the veins to appear hypointensity to weighted images. So, thin line or a dot visualized in two perpendicular planes, central in location, run partially or entirely throughout the lesion. Any lesion which is excluded less than 3 minutes, I can show you the plot with a central vein. This is how it appears, and you can see that this is the central vein site. So central veins were present in the thalamus, cerebral long pons, and spinal cord. Finally, the phagocytic imaging. Addition of contrast agents on the magnetic nanoparticles with phagotropism targets inflammatory cells, directly causing the disease process. So ultra small USPIO, which is already I showed you TPSIO. This is ultra small paramagnetic iron oxide nanoparticles taken up by the microglia and myeloid effector cells. FDA approved iron oxide nanoparticles, the peroxetol, and does not replace MRI contrast, but it can say what kind of cell which is present. So I stop here. I don't want to go into the MRI MS mimic, which is thank you for your attention.
Thank you, Dr. Lakshmi. I think in such a short
span
of time, you covered so much in this lecture, right up to the complications. Thank you.
I have finished on time.
Yes. I mean, I say that, but fantastic. I think today's session was fantastic. I hope it has given all the PGs the expanse and as well as the depth of all the topics that we discussed, MS as well as optic neuritis. And I hope it will give them the perspective when they prepare both for their theory as well as their practicals. Any comments from my faculty? Dr. Lakshmi, you want to say something, please?
Sir, your efforts are really excellent, Dr. Shripad. It will be very useful for my postgraduates. And somehow I find I wanted to inform Bhavesh that you should inform more residents. I was surprised that the number of participants are pretty less. It all depends upon how much. Most of the boys would be delighted to attend such talks because I'm sure they learn quite a lot in such a short span of time.
Absolutely.
The essence is given. Essence is given to them. You know, for this to learn and understand this, they have to spend at least many hours, which they get it in 10-15 minutes. Especially the pathogenesis talk by Shruti, the initial talk by Dr. Kapila. So I really enjoyed the whole session.
Yes.
And the criteria by Netravati with the clinical scenarios, I really enjoyed. Whether the residents enjoyed or not, at least I learned quite a lot. Thank you.
Thank you.
Thank you, everyone. Bye-bye.
Goodbye. Good night. Thank you all and have a good night.
Good night, sir. Thank you very much for inviting such a wonderful night today. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.